Hi there, my name is Dr. Laura Kehoe. I am a primary care physician and addiction medicine specialist, and I'm thrilled to be here today to talk to you about low threshold care. We're going to start with a case. This is a 34-year-old man with severe opioid use disorder who had a recent overdose and comes to your office requesting buprenorphine after having been released from incarceration 1 week ago after 6 months there. He has documentation that he was maintained on 16 milligrams a day of buprenorphine naloxone while he was in jail. And he tells you that he used fentanyl on the day of release and bought an 8 milligram film yesterday from someone, which he took and he tolerated it well. So he comes to your primary care office and you have some questions. And these are some common questions that we hear from new prescribers. Should I and can I prescribe buprenorphine today? Do I need further information? Why was he purchasing it? Isn't that diversion? And should I be concerned about that? How do I even write the prescription? What if he continues to use fentanyl and is really complex? And will I have the bandwidth within my practice to actually care for him? And how often do I need to follow up with him? So taking a step back, there is a dire need for on-demand, low-barrier care. We're in the midst of the worst crisis our country has seen in drug overdoses and deaths. And qualitative studies have shown that people who use drugs have identified, and we see, or have ongoing challenges facing really, really high barrier care and numerous barriers to engage in care, even to get that foot in the door. First and foremost, stigma and discrimination is leading the way. Patients also don't know where to go or how to get there. And they're often balancing competing priorities in life, like parenting or work, or trying to find housing or other appointments, challenges with travel. There's really a history of extremely complicated registration and multi-step intake processes that really are not consistent with the urgency of this crisis and the need to get people onto life-saving medication. And really underscored is the legacy of really past negative experiences with treatment providers and systems, where our patients are absolutely not not able to trust us. They're conditioned not to trust us because of really traumatic experiences with historic substance use disorder care that has not been consistent with what we know about the evidence and about patients and patient-centered care. Providers have also identified barriers on their end. Also, stigma related to medications and patients with opioid use disorder, provider experiences with patients not understanding and really kind of driving their approach through beliefs rather than the evidence, and concern about logistical issues, worries about time and cost and insurance regulatory requirements and barriers, and feeling unprepared and not having the knowledge about opioid use disorder and the excellent treatments that we can provide them and the role of medications. Low threshold care, let's talk about the definition. What does that mean? It means exactly what it says, lowering the threshold to care. It means same-day treatment entry, a very quick entry and immediate access on-demand medication for opioid use disorder, a harm reduction approach where we meet people where they are, we engage them, we start with compassion and trauma-informed care, we have a flexibility in our regulations and requirements around the approach to actually engaging them and starting where the patient is and providing them with immediate care, and really providing this low threshold care in a variety of places where people with opioid use disorder may go. It need not be in a typically structured substance use disorder setting. This could be anywhere along the continuum of care within a hospital setting, within outpatient settings. It could be in a syringe exchange program, outreach vans, really in non-traditional settings that can increase access for marginalized populations or homeless individuals and patients who inject drugs. So the question, should I or can I prescribe buprenorphine today? Do I need further information? So as a reminder, this person has come to you. He has a known diagnosis of opioid use disorder and documentation of recent buprenorphine management. He meets DSM-5 criteria. He tells you he's tolerated buprenorphine after a very short one-time return to use after a period of stability while incarcerated, and he's extremely high risk of overdose. So this is someone, there should be no delay. You should give the buprenorphine. You should feel confident and really proud that you can provide this life-saving medication to this person who is coming to you and is asking you. So this is actually the best case scenario. The further information you actually need is about him. What are his goals? Is his goal to be abstinent and to continue the buprenorphine to fully stop using opioids? Or is his goal to use less chaotically and to stop overdoses as he's engaging in care? Does he have a history of precipitated withdrawal that you need to know about? Is his dose appropriate? Did the 16 milligrams hold his cravings while he was in jail? Or has he, while he was in there, continuing to crave, and now that he's out in the community facing numerous stressors, is this something that we need to think about optimizing his dose or advancing his dose? And asking him about overdose prevention strategies and providing him with naloxone, talking to him about safer use equipment, providing him with that, and really underscoring your plan to stick with him and to work with him and to continue to partner with him with the next steps during this high intensity time, this high risk time. So back to the question about why he's purchasing buprenorphine. Isn't that diversion? Isn't that something we should be really worried about? Well, we know that and this is again, qualitative studies, and what we hear from our patients and what we see is that common reasons for diverted buprenorphine is because people don't have access to care. So it's really a workaround to the challenges our patients are facing with high barrier care and lack of adequate care. Also, subtherapeutic dosing, which we'll talk about. People who use drugs often use with other people that they care about who also may be having a hard time engaging in care. And so if they have a medication that can help someone alleviate their withdrawal, help them to stop using, you'd be pretty hard pressed for any of us to be in that situation and not share with another person. And also, this is something that we know is when people take buprenorphine diverted, they're actually taking it to alleviate withdrawal symptoms, for symptom relief or to stop using. They're not using this to get high, which is a common urban myth. And so the best way to decrease diversion, if this is a concern, is actually to increase access to care. And within the treatment spectrum, when you're caring for someone, if you have concerns about diversion, there are ways that we can increase the level of care. First and foremost, we want to deconstruct the concern about diversion and ask the patient, have open communication about this. It is very common, as you've heard in other discussions in the mini course here, we are seeing our patients experience precipitated withdrawal or having very challenging times initiating buprenorphine, and that may be a reason why they aren't taking the medication. They may be having a challenge with having other people, as we said, that they're with who also are in need of care, and so they're not getting a therapeutic dose because they are sharing it. Or we are underdosing them, and so they're taking the medication to alleviate withdrawal or cravings in order to avoid exposure to fentanyl, and hence running short or running out and then having to purchase more. And so there are ways that we can, keep that door open, share your concerns with the patient, have shorter prescriptions, see them more closely, potentially do an in-office induction where we help people to initiate onto the buprenorphine, and ask, do you have somebody that you care about who's in need of care, who we can get them into care so that they get their appropriate medication and you get yours at the right dose. What we don't want to do is deconstruct the patient with assumptions. We really want to ask the patient about what's going on. So how do I write the prescription? It's very simple. You do need to check your state prescription drug monitoring program for every buprenorphine prescription. It's a Schedule III under the DEA medication, so it's a controlled substance. But because it's a Schedule III as opposed to a Schedule II, you can call it in. It can be taken as a verbal order if needed in an urgent setting, for example. And you would just need to follow up with the hard copy thereafter. But in general, you pick the formulation and the length of the prescription. In general, buprenorphine in the outpatient setting comes in sublingual film and tablet. And for the treatment of opioid use disorder, depending on your state, there may be a preference for, and your state and the insurer, there may be a preference of film versus tablet. But in general, it's the dual product of buprenorphine naloxone. And you would write for this person the 8/2 milligram film, place 2 films under the tongue daily for 7 days. If the person and you decide 7 days is too much, he would prefer a shorter prescription because of safekeeping or for whatever reason. You could write a shorter prescription. You could certainly write a longer prescription, but in general, when we're starting patients, we want to start with roughly about a week and see them back to see how they're doing with that. And in this case, this is a person who's coming out of incarceration where he had been stable on an average dose of 16 milligrams a day and may need adjustment as he's now come out into community living. So back to our patient. Your patient actually misses your in-person follow-up the next week. He calls and he says he's doubling up right now with his sister. He doesn't have a stable place to stay. She lives far away and he has started working, so he couldn't come. He tells you he is having cravings. He's not sleeping well. He's used fentanyl twice this week, and his dose is 16 milligrams of the buprenorphine naloxone daily that you have written for him. So questions you may have. Should you continue prescribing without seeing him? You saw him last week. He didn't make it to this appointment. Is he taking the buprenorphine daily and then using on top of it? Or is he stopping the buprenorphine and then using? Is he having symptoms of precipitated withdrawal with use? Are there any challenges with his access to his full dose? Is his dose adequate? What else should you do to decrease his harm and overdose risk? He's told you he's using fentanyl. And when can he return for follow-up? So this kind of underscores, what if he continues to use or is complex? Will I have the bandwidth? So this is a very important slide by Sir et al. It's from 2016. And the simplified view of this is that this was a 60-month trial of patients with opioid use disorder who back then were randomized to no treatment, to buprenorphine, and to methadone. And as you can see, at the end of 60 months of this trial, that patients in the beginning were using, before they started medication, were using several days of the month. And over time, those numbers of days in both buprenorphine and methadone patients actually decreased over the month. And why this is important is to show that as they were engaging in care and staying in care, their overall use was decreasing, but it didn't get to zero overnight. Just like our patients with diabetes don't get to perfect hemoglobin A1Cs overnight once we start them on insulin or oral hypoglycemics. So if you just manage this patient based on abstinence, when we know the natural history of opioid use disorder is that it takes time. It may take time for people to actually get to abstinence if that is their goal. But we know that keeping people engaged in care and retention is incredibly important. Keeping them safe while they're using and understanding the overall trajectory is critically important to the management of patients with this condition. And early use during treatment is expected and should be expected. So this is actually somebody who's telling you he's comfortable enough to share with you what's going on. He's also at a very high risk, and he's telling you that he can't come to appointments. And this is where low barrier care is very important. And we're lucky that we have the ability to do telehealth. It doesn't mean we don't want to see him. It doesn't mean that this is somebody who it makes sense to never see him again. It's just that right now he's very early on in care. He is demonstrating the need for connection and optimization of his dose, and we want to keep him engaged as best we can. We also know that treatment retention is not only a core and key important piece of treating patients with opioid use disorder. If they're not engaged in care, we can't help patients. But we know the longer that people stay in care, the better they do. And it has benefit irrespective of toxicology results. And in this study, this really showed that treatment retention is strongly associated with quality of life. And the toxicology results were not the ultimate decision of how somebody was doing. We also know that we see increased retention when the doses of buprenorphine are optimal. And there's a growing body of literature supporting what we're seeing clinically, which is that people are needing higher doses of buprenorphine. Much of the data that we have guiding us for dose targets for buprenorphine is really dated literature, and it came from before the fentanyl era. And this is actually a study from 2023, just last month, that basically was a cohort study of about 6,500 patients who were initiating buprenorphine between 2016 and 2020. And those prescribed the recommended daily dose of 16 milligrams were at significantly greater risk of treatment discontinuation within 6 months than those who were prescribed a higher dose of 24 milligrams. This study here really reviews the evidence on buprenorphine dosing limits and outlines how the targets that are currently out there and the FDA guidance on buprenorphine that recommends a target dose of 16 milligrams per day with a range of 4 to 24 milligrams really is outdated. The initial studies that were done to provide this guidance were done well before the era of fentanyl. And on the left-hand side, you can see this is a study of buprenorphine plasma concentration versus time at different doses. And this was actually a review of a 24-hour blood sampling period after once daily dosing in 5 volunteers who were dependent on heroin and maintained on 0, 2, 16, and 32 milligrams per day of buprenorphine. And that red thick line indicates 3 nanograms per ml is at the level required to suppress drug liking. And this was of high-dose hydromorphone challenge, which is also significantly less potent than fentanyl. And that red shaded area is indicates the concentrations where that drug liking occurs. So this again, the conclusions are that decades of independent research establish evidence that individualization of doses, at least up to 32 milligrams per day, increases patient safety and retention and care, and that the current FDA guidance for buprenorphine dosing, the target of 16 milligrams in that range of 4 to 24 milligrams with strict dose limits less than 32 milligrams in the context of widespread lethal fentanyl is really outdated. On the right-hand side, Moss et al. Also did a study of people who had opioid use disorder and found that really higher concentrations of 5 nanograms per ml were actually most effective in protecting against fentanyl-induced respiratory suppression or overdose. So again, in terms of drug likability or craving, we're behind the 8 ball, and also for overdose protection. Some highlights about providing buprenorphine extended release in low barrier settings. It's great to have this on hand. There are some logistics to know about. So it's a Schedule III substance, the buprenorphine is, so you need a DEA license for each site where you are going to be providing this. And your organization has policies adherent to the DEA, and there are state and local regulations for handling buprenorphine that need to be sorted. For medication storage and tracking, there needs to be a secure double-locked storage system. If required by the manufacturer for the formulation of extended release buprenorphine that you are having on site, that refrigerator needs to be tracked for appropriate temperature, and there needs to be a medication log system. Some clinics have an Omnicell, many don't. You don't have to have one. You just have to make sure that you have a medication log system. And then medical records that are adherent to the DEA and state regulations, as well as adherence to 42 CFR regulations. And then organization, policies, and education. There are many organizations have specific policies and procedures and workflows related to the injectable buprenorphine, training for involved team members, and assessing competencies. Seeing this written out, it sounds like it's a lot, but there are excellent resources to guide you through this, and the barriers have gotten much lowered for providing this really important formulation of medication. And I would say the biggest difference is the delivery method. There are two options. One is to buy and bill, which is what we do in our clinic. And those are policies adherent to the REMS certification and DEA, and then specialty pharmacy, which many other clinics use, and there are policies adherent to DEA regulations. We'll go through just honing in on that a little bit, the difference between specialty pharmacy and buy and bill. As you can see, some of the major differences for specialty pharmacy is that's where the healthcare clinic or office will order the injectable buprenorphine for a specific patient from a REMS certified specialty pharmacy. It's usually dictated by the patient's insurance. And once the medication is approved by the insurance, the pharmacy will then coordinate with the clinic for the delivery to the clinic. Upon delivery, the clinic staff will appropriately log and secure the medication until it's time to administer it to the patient. And this is what most health centers utilize for injectable buprenorphine. Because it is done this way, it will show up on the prescription drug monitoring program. And there are some resources here through the REMS program. Buy and bill, on the other hand, is a medical benefit as opposed to a pharmacy benefit. And this is where the healthcare clinic or the office will purchase injectable buprenorphine directly from the specialty distributor. The medication is delivered to the clinic, again, logged appropriately in the clinic by the clinic staff, and secured in that stored on-site, allowing the injectable buprenorphine to be in the refrigerator or in that secured site. So when patients come, it can be pulled on hand. And so there's no delay in waiting for the patient's prescription to come from the pharmacy. When the medication is administered to the patient, the clinic then bills and submits the claim to the patient's insurance for reimbursement. And with this method, the healthcare clinic assumes the cost of the medication up front, but after they administer it, they do bill and get reimbursed. This will not show up on the prescription drug monitoring because it is billed as a medical, not a pharmacy benefit. And the clinic will just need to work with the DEA certified third-party reverse distributor. So a wrap up of pearls for practice for providing lower threshold opioid use disorder care with buprenorphine. The general take homes are buprenorphine is a life-saving medication, one of the most effective medications that we have in all of medicine. So please don't delay. Start buprenorphine if you have a patient with opioid use disorder. If your patient finds that it's not working for them, please work with them to figure out why, rather than just stopping. Deconstruct the ongoing use if their goal is to stop. Deconstruct concerns about diversion. Really work with your patients and look at this condition through the lens of other chronic relapsing conditions that you're already expert in. This is really just about the medication at this point and learning how to really provide it. Toxicology should just be a tool in your shed. It should not be a weapon, and it should not be the be-all and end-all. Please remember functional status and improvement, and centering the patients at the core of this treatment team. They are the people who are living with this. Their goals should be supported and underscored, and we're here to really bring in evidence-based, patient-centered, trauma-informed care. In terms of buprenorphine, this mini course is about buprenorphine. As we said, there are many challenges, and it's not always the right fit for every patient. So please don't forget about full agonist methadone that can be dispensed in opioid treatment programs, also working very hard to lower barriers to access to methadone. Here's a wonderful quote from a patient that really wraps up the benefit of taking this approach with patients and helping people stay engaged in care and sticking with them. What I remember most from you about the visit was the kindness of you and your staff. My second biggest takeaway is that you treated me like someone who has a medical problem, and no one else had ever done that. So I would say out of all of this, with all of the education that you're learning about buprenorphine in particular, going back to the basics to lower barriers to care, probably the biggest tool you can bring to this is really remembering the trauma that our patients have experienced, the stigma that they have experienced, and starting there in addition to immediately providing them with medication to decrease their risk of overdose and dying. Thank you.